Good afternoon and good evening. Thank you so much for joining us for the weekly briefing from Africa CDC. My name is Margaret Edwin, the Director of Communications. I'll be moderating this session. The weekly briefing focuses on advancing the Africa's health security and sovereignty agenda with a focus on health emergencies across the continent. And today we are joined by Professor Yap Boom, the Deputy Incident Manager from the Incident Management Support Team based out of DRC. And just to remind everyone that we have French translation on channel 2. I will now hand over the floor to Professor Yap to start the session. Over to you, Prof.
Thank you, Director. So good morning, good afternoon, good evening, depending on where you are. It's my pleasure, as you know, now to take the press briefing on behalf of our Director General, His Excellency Dr. Jean Kaseya, who's actually traveling to Tanzania. As you recall last week when you were making the presentation, highlighting that the President Samia Hassan has been appointed as the AU champion for maternal, newborn, and child health. So it's important to go and discuss with the President and see how she will be able to support that task. So it will be my pleasure to go through the different way of implementing the vision of Africa security and sovereignty, as we will see in terms of laboratory, but also in terms of digital transformation, and of course, giving you an update of what is happening in terms of outbreak. We'll see the cholera, the mpox, but also what is happening in DRC with the meningitis. So I will also take advantage, as you know, to thank all our soldiers who are fighting all those outbreaks, but also all those crises. We have the cyclone in Madagascar. We have many of those challenges that have been faced in many of our countries, and even beyond. You are all aware of the crisis that is being faced around the world. So we really want to appreciate all the health workers who are giving their time, their energy, their passion to ensure that all of us are safe. Over to you, Director. Oh, thank you. So last week has been an opportunity to have our DJ himself giving an update of the situation of Africa CDC. And as he mentioned, that's an exercise that he will be doing himself every last Thursday of the month. And as you see here, he was engaging the African Union partner group that was visiting Africa CDC, because it's critical to have all those partners, all those supporters of the members of the African Union to ensure that, one, we have the same understanding of the new vision that is just the translation of the instruction, the recommendation of our leaders. And if you recall, this has been endorsed during the AU Summit as the transition from the new public health order to the Africa health security and sovereignty agenda. So it's important to have all the partners group to come and listen firsthand on what the vision is about, but also appreciate the infrastructure. As you can see here, they were able to visit the building, but more importantly, to sit in our EOC, which is definitely the largest in the continent. And in the keynote, what was highlighted was the strong alignment behind the country-led priority, which is critical to strengthen health security and the resilience across the continent. Remember, the vision is country leads, the institution, the region coordinate, and the global support. So the leadership has to be implemented and present at the national level. Next slide. I mentioned that I will focus a bit on one of our pillar. You remember the HSSS are 5 pillars. You have the reform of the global health architecture. You have the PPPR, the preparedness, prevention, pandemic and response. You have the financing, you have the local manufacturing, and you have the digital transformation. So these articles highlight the Charting Africa Digital Public Health Future and highlight straightforward 5 priorities for action. The first one is to have a unique digital health identity. And that need to establish a digital health card with a unique identifier for every citizen. From the time they are born, it will follow them so that we enable electronic medical record and improve cross-border surveillance and continuity of care. And of course, we are talking about health, but it will integrate all the information that a citizen will need to have during his or her life. The second one is to digitize the community and primary healthcare. You've seen that we have the target of 2 million community healthcare workers by 2030. We are already at 1 million. But those one will need them and the health facility to be equipped with the GS2-based digital tool to enable real-time reporting, stronger surveillance, and improve service delivery. Because it's only when you can detect early and appropriately that you can control outbreak at the source. But also, in terms of those emergency, to develop a second generation of DHEOC platform, which will combine on one side the health program, but also the outbreak response, because eventually those community healthcare workers, when they are within the community, they will serve both. They will strengthen the primary health care, but also they will be the key component for the alert, the surveillance, the monitoring, and the response to the outbreak. And if those ones are well equipped, then we'll be able to control quickly and therefore reduce the impact of those outbreaks. And the fund that will be generated will be now used to support other programs. The fourth one is to build a continental public health data center. Really, the idea is to strengthen Africa CDC Data Hub to securely host and analyze health data across the member state and support the epidemic intelligence and coordination. The idea is, you've seen the EOC that I've shown you. It would be great to have a map and see all what is happening in a real time within the continent. Therefore, we can quickly send teams in the field supporting the member state so that they can control the outbreak or any other public health emergency. And the last one is to create an AI-enabled knowledge hub. The idea is to develop a continental platform that uses AI to synthesize and share public health knowledge in real time. There are so many data that are being generated. So we need to find the most efficient way to analyze the data and to provide information that will support the decision makers on making the efficient decision. Next slide. We also want to bring some light on the laboratory. The surveillance, the response rely on the ability of country to detect quickly and to detect in an efficient way. You've been hearing us talking about the lab decentralization that we've been seeing in many countries during the outbreaks. So this earlier, it was the opportunity for our Center of Laboratory to move around the different member states. And with the partner, you see that there was some mission together with WHO Afro and see how the different components of the laboratory are being strengthened in a different country. So in Kenya, the issue was about the referral specimen to see how they can have an holistic way of collecting and referring sample. In Madagascar, it was about Mpox. As we'll see later, Madagascar is one of the hotspot countries as we do speak now. So providing them the training was critical for them to ensure that they decentralize properly the response to Mpox, which will support the response to other outbreaks. In Senegal, it was really about the network of laboratory to emphasize the cross-border data sharing for early warning. I think Senegal is one of the example with the 4S Sentinel that they have to share with other countries and to see how the integration of lab goes beyond outbreaks, but also include the surveillance of antimicrobial resistance, which you remember last week we consider as the next and silent pandemic. So in Senegal still, it was the opportunity to reinforce, to strengthen the partnership with WHO as lab is concerned. You know, the IMST has different pillars. Lab is one of the most critical. And then we were happy to see that strong collaboration with the two organizations, ensuring that the member state will receive the appropriate support in terms of decentralization, in terms of molecular, but also in terms of sequencing, which has also continued in Comoros, as you can see. Now, in Togo, I think it's important to commend the Minister of Health of Togo, which has decided that the ISO 15189 should be considered as the norm for all the laboratories within the country, not only at the capital city of Lomé, but really going as far as the district level. So it was the opportunity to go and support that award, to see also how these best practice can be scaled to other countries. Going to Nairobi, the issue was really to emphasize the importance of biosafety, biosecurity. We are dealing with all those pathogens. So if the colleagues in the lab are not properly trained, therefore they will be at risk themselves. You remember disease like Marburg disease, it started in the lab, and because the proper biosecurity measure was not implemented, that's how the virus spread and killed people. That's why we have that name of Marburg virus disease. So we don't want that to happen anymore. We want our lab to be the safest place for our colleague, but also to ensure that any virus, any bacteria remain within the laboratory. Next slide. Still in the laboratory, the strategic picture and the way forward is really to have the specimen system on one side to strengthen the lab infrastructure build out. I mentioned Comoros, how we support them to move from the molecular to the sequencing. I think as per today, up to 48 member states have the capacity to sequence within their country. That is quite significant. They can do the sequencing for Mpox, for many other diseases, and for the surveillance of antimicrobial resistance. That is critical. But we've also learned that laboratory should not work in silos. That's why it's the importance to re-emphasize of regional network integration, the RESOLAB, the WHO, Africa CDC collaboration, to avoid the fragmentation, to ensure that we have that proper integration, especially at this time where the resources are quite limited. And of course, I mentioned the quality management, the biosafety with Togo as a great example that we as Africa CDC would like to scale up and ensure that all those labs has the adequate biosafety and biosecurity measure. Next slide. Now, going back to the overview of our public health event that we monitor in a weekly basis. And you remember what you heard last week, our target is really to significantly reduce the number of high and moderate risk events by strengthening the capacity of our National Public Health Institute, the capacity of our CUSP that will be able more and more to detect early and therefore to contain the outbreak at the source. So as you can see here, cholera is the top country in terms of number of deaths that we've been seeing in the continent with 390, followed by measles 262. We have Mpox, which is the largest in terms of country affected with 22 that has been affected so far in 2026. Then we have diphtheria and dengue. Next slide. So we will talk about DRC 3 times during this press briefing. Now we are talking about meningitis. We'll talk about it for Mpox and again for cholera, highlighting the challenge that this large country is. And that's the reason why our Director General was here in DRC over the weekend to engage with the Minister of Health and at the highest level to see how the country can be supported, because this is also the country that has Ebola outbreak, as you remember, the 16 that was happening in the continent. So the support to DRC has to be special in many ways. The country has shown leadership on domestic financing with the 2% taxes in importation that will be invested in health. It's important to support them. That's why it will be one of the first countries that will receive a financial expert deployed by Africa CDC that will sit nearby the minister, and the minister has approved that person to come and sit there. And that person will support the minister on working on one plan, financial plan, to ensure that he has visibility and that all the other partners will come and support that very plan. And that person will also be the one making the connection between the Minister of Health and the Ministry of Finance. So that is a critical support that will happen not only in DRC, but also in 20 other African countries. So as meningitis is concerned, we've had 24 suspected cases, 3 has been confirmed. We have seen 9 deaths with a case fatality of 38%, which is quite high. So as you can see here, it happened in Mangembo Health Zone. It started actually in a school, in a dormitory. And then from there, the purples spread and it went up to 6 villages as we do speak now. And the causative organism is Neisseria meningitis W135. And this one specifically is not covered by the current vaccine that is being used in the routine that will cover mainly the Neisseria meningitis type serogroup A, which also raised the challenge of ensuring that we have good data on the germs that are circulating. We are talking about Neisseria, but it might be the same thing for HPV, for pneumonia, also to ensure that we have the proper understanding of the serotype. Therefore, we will recommend the adequate vaccine that will cover all those ones. So this is one good example of the work that we have to do to combine the generation of evidence through our research and the policy to respond to those outbreaks. So in 2022, the country had 75 cases and 20 deaths due to still Neisseria, but that at the time was the type C that was reported. And at that time, the Penta vaccination coverage was 96%, highlighting that good vaccination coverage, but not covering the serotype that is currently leading this outbreak. However, the country is responding by the establishment of the incident management team in the provinces and then the ongoing support on the development of the preparedness and response plan, as well as the ongoing case management and risk communication and community engagement activity. Next slide. Going back to Mpox, which was the initial disease that brought us all together, we continue to see the decrease in the number of suspected cases and confirmed cases. We currently have 33 members that have been affected since the beginning, but at this point of time, we have 22 countries that has been affected. Now we have Madagascar, we have DRC, we have Guinea, we have Kenya, and we have Liberia that contributed for 80% of the case for the last 6 weeks. So what has happened is, since the Mpox has been listed as a public health emergency of continental security, we have 3 months to do what we call an after action review to ask all ourselves what went well, what went less well, and how do we want to improve the response, the transition that will be happening soon. So this will happen in the next few weeks. Next slide. So you may have heard the news of these new recombinant Mpox strains that two confirmed case has been found in India and in UK with no secondary transmission. So at this point, we can say that there is low risk for general population. However, it's important to highlight that these recombinant, it's bringing together the clade 1B and the clade 2B. Those two clade 1B and 2B are sexually transmissible, and the 2 strain that has been isolated seem to have a common gene that is coming from the 2 of them. So what we are seeing here in India and UK might happen in many other African countries where we've been seeing the 2 different clades. So the colleagues from INRB, from Cameroon and other are currently sequencing to track and see if these recombinant are not also found, have not been circulating in our environment. So now the key question that is raised is, does this hybrid spread more easily between human than the original clade? And of course, the critical question is about the virulence and the severity. So those questions are not yet answered. As I mentioned, there is only 2 confirmed cases, and then there is an investigation that is continuing. But it's important to have that alert to know that this is happening and reminding us that, yes, we've lifted the mpox, but there's still some dynamic that we don't know, and we still need to carry the prevention and the transition so that countries are capable to limit that in case there is any new surge of case in the territory. Next slide. In Comoros, as you can see, there is a decrease in the number of confirmed cases from 4 to 1 case this week. Still, we have 0 death, which is good. The testing rate is still very high, 100%, 17% of test positivity rate, which is good, meaning that the surveillance is going on well. So at this very point, we are supporting the country on the planification for the vaccination. So we work together to submit a plan looking at 10,000 doses of vaccine that can support the country to control the outbreak with a focus, a targeted vaccination on the more vulnerable population, but also the super spreader, that those are the ones who will most likely transmit the mpox. Next slide. In the neighboring country, Madagascar, where the situation is a bit more complex because Madagascar has been affected by the cyclone early February. So they have on one side the cyclone that they are trying to respond, but also now the mpox. And next week, there will be a joint mission of the African Union, which will combine the African Union Commission and Africa CDC to go and support in the different needs. So there have been some engagement with the member state to agree and properly understand the needs. So there will be some need in terms of food, in terms of support, but also, as you mentioned, as you imagine, some need in terms of health to prevent a potential outbreak like cholera, which usually happen after those kind of cyclones. So as mpox is concerned, we are gladly seeing a stabilization of the outbreak with 63 cases last week, and this week 55. The test positivity rate is still high. We were discussing this morning with the country when they were presenting during our weekly briefing, and then seeing the challenge that they have in active surveillance. Therefore, we'll support them with the deployment of AVOC, most likely next week, so that they can go and have that active surveillance being present in the community. Also with the risk community communication and community engagement to ensure that we can capture the positive case within the community and not in the health facility, as we do see now with this high test positivity rate. But today we gladly saw that Madagascar launched the vaccination campaign, the target vaccination campaign for mpox. But more importantly, Madagascar will be the first country in the continent to use the fractional dose. What it is, it means that with 1 dose of mpox vaccine, you can vaccinate 4 to 5 people. So this is the first country in the continent that will be using that. So it's an opportunity to generate evidence so that we have those strong evidence that will now help us to understand how it works in our setting, but also to convince other countries to do the same if needed. And knowing that we are moving from a reactive to a preventive vaccination for mpox, where we want to achieve the herd immunity, especially in those endemic countries, DRC, Cameroon, and so on, it is critical to see with the limited amount of those that we have, how we can multiply the number of people that we can reach. So Madagascar is giving us a very good example on how we can use science and research to respond to outbreak. Next slide. In Liberia, currently, we also still see the stabilization of the outbreak from 4 to 3 cases this week. So far, 1,629 cases have been confirmed out of 173, with a case fatality ratio of 0.5%. So it is still in Montserrado that we have the highest proportion of number of confirmed cases, and this is also where the 3rd round of vaccination is being planned. So really to circle that place and to provide the vaccine, still using that target approach where we have those specific population that we want to target, those that are the most vulnerable with HIV or other disease, but also those who are most likely going to transmit the disease. Next slide. In Mali, we've seen some small reductions of case from 0 last week to 6 confirmed case. So we are supporting the country, which at some point was requesting some vaccine so that they can also use the different approach. I keep on talking about vaccine, but we know that that's not the silver bullet. The most critical is the surveillance, active surveillance. And you can see here that the test positivity rate is 86%, which means there is no active surveillance in the community. So that's where we also support the country before even talking about the vaccine that might take a bit of time to reach in the country. Next slide. Now, talking about the vaccine themselves, 5 million doses of vaccine have been delivered to 17 countries as we do speak now. But what is new as compared to last week, I just mentioned that Madagascar has launched the vaccination with the fractional dose. And then we have Cameroon and Comoros that have submitted their plan, their request for vaccination. So each of them were requesting around 10,000 doses to tackle the outbreak in the country. Next slide. Now, moving to cholera, once again, we are talking about the DRC, which is the country that reported 64% of all the cases and 80% of the death reported in 2026. Mozambique, together with DRC, contribute to the 87% of the case that we've been seeing since the last 6 weeks. Now, Sudan declared the end of cholera epidemic, and I will highlight some of the key driver of the success that we've been seeing in Sudan. Next slide. So what you can see here is the country where we have seen an increase of the number of cases. In red, you have Angola, Mozambique, and Zambia. So the increase is relative, but when you look at the actual number of cases, you will see that Mozambique is definitely the country with the highest number of cases in terms of increase. Though DSC, we can see that slight decrease of 12%. Still, we are talking about 4,000 cases that have been reported within the last 6 weeks. Sorry. Next slide. In Zambia, we continue to see the decrease in the number of cases moving from 53 to 32, though we had 2 deaths as compared to 0 deaths last week. The case fatality ratio remain quite high. We have almost 2%, while the target that you now know is 1%. So this is due to the driver that I highlighted, the contaminated water source, the weak healthcare system, especially as cholera is concerned, and the challenge in urbanization and infrastructure gap. That's why the communication that we are having now, the conversation with the World Bank and other partners, is to ensure that the plan for water access are also connected to the hotspot for cholera, so that when a country like Zambia plans to build some water spot and so on, they have to prioritize the place where usually we have the case of cholera. Next slide. In Mozambique, as I mentioned, is definitely one of the country that is the hottest as we do speak now, after DRC, of course. The number of cases are decreasing slightly, but I will say more stabilizing from 663 to 610. The number of deaths have also reduced. So the OCV coverage is 3.5 million reactive and 2.5 million preventive. And remember, what we really want to see is the increase of the reactive vaccination, especially now that the dose available at the global level have increased. This morning, we were having the neighboring country, Zimbabwe, and then they were highlighting that it's critical for them to do the preventive vaccination on the districts that are bordering Mozambique, because that's usually what happens. You do the vaccination in one country, and by the time you stop that one, you already have the kids that have moved to the other country. So this is an important evidence of how the need to strengthen and actually to accelerate the cross-border coordination is critical. And that's why in the next few weeks, we'll have those meetings with UNICEF, WHO, to ensure that we have that strong cross-border collaboration and supporting those southern countries in Africa. Next slide. So in DRC, we come to DRC, as I mentioned, we had the meningitis, we have the mpox, now we are talking about cholera, where the cases are slightly increasing with the same driver. In the east, you have the conflict and displacement, the challenge of access in the north and south Kivu. It remained difficult to really have an impact and to improve the access to water in these places. But also, even in Kinshasa, there is a lot of effort. You remember we were talking that last week, the interaction review in DRC had happened, highlighting the need to have a stronger involvement of other sectors, especially those in charge of making access to clean water. Because if even in the capital city we have those outbreaks, it's because the access to water remain quite low in some of those places, therefore leading to those outbreaks. Next slide. In Burundi, we really want to highlight the great example that is given by the First Lady, trying to bring together the public and the private sector to fight cholera in the country using different approach. First of all, the risk communication and community engagement. You can see this event will gather quite a number of children in school, because those are the first ones who will now get the good practice. And when back home, they will ensure that they also contribute to educate their parent and family on the good thing to do to protect themselves against cholera and other disease. So the partnership with the private sector is also to increase the access to quality water, especially in Bujumbura, that remain critical. But also the challenge that's happening in the other part, particularly in the Nyanza Lake, where the untreated lake water is being used by the population and therefore continue to sustain the outbreak. So it's something to comment and to ensure that the type of partnership also scale at the continental level. Next slide. So we've mentioned that Sudan has declared end of 18-month protected cholera epidemic. And as you can see, some of the key driver is the vaccination, with approximately 20 million vaccine doses that were administered since 2024. This is quite important and highlighting the impact of the vaccination, but also appreciating that this is not a silver bullet, because this outbreak has ended. But if the access to water is not being implemented, next year, when we have the next rain, we'll have another outbreak coming. So while we are celebrating the end of this cholera outbreak, it's critical to accelerate the access to clean water in the country, and also maintaining the routine surveillance and having rapid response team that remain active to prevent any resurgence of disease. This is what of the critical advice given to the Minister of Health. Next slide. So now, in summary, the key highlight of the week was, of course, the endorsement of the Africa Security and Sovereignty Agenda. I highlight the Digital Public Health Charter, which is the future, with the 5 priorities that I've mentioned. I also highlight the importance of the laboratory, which is the cornerstone to respond to all those outbreaks. As mpox is concerned, we have this new recombinant. We have some countries that we are really targeting: Burundi, Cameroon, Comoros, Madagascar, Mali, South Sudan, and Tanzania, with increasing transmission in the last 6 weeks. And we have DRC, Madagascar, and others who are contributing to 80% of the case. As cholera is concerned, Sudan declared the end of the cholera outbreak, which is great, but also re-emphasized the need to strengthen the WASH component so that we avoid having those outbreaks in the future. And then we appreciate that DRC need a special attention for cholera, for mpox, for meningitis, and that's the reason why the support in domestic financing is critical, as Africa CDC will be providing to them. So with that, I will be very happy with all my colleagues in the call to take the question for the journalists. Over to you, Director Margaret.
Thank you very much, Prof. Let's take the first two questions. I have one here from Inez, who's from the APM Market Access. The question is, since discussions on health financing and sovereignty at the Africa Union Summit, what concrete steps has Africa CDC taken to advance the initiatives announced at the summit? That's the first question. And then I have another question here from Ayele Addis, who is from the Africa News Channel. The question is, how is the incident management support team prioritizing response efforts across multiple simultaneous outbreaks? So those are the first two questions. I hand the floor back to you, Prof.
Okay, thank you. So for the first question, I think from Ines on the health financing, I think the concrete action, the summit happened 2 weeks ago. Last week you were here having our Director General, Dr. Jean Kaseya, and right after that he flew to DRC. You've seen DRC is a country where we have mpox, have cholera, we have now meningitis, we had Ebola. But this is also one country that data have shown that the country is losing $800 million every year because of the ghost workers, those inefficiency. So that's why the DJ came to discuss with the Minister of Health and the highest leadership in the country to see how Africa CDC can provide that specific support by bringing expert in finance management. And those experts will sit in the cabinet of the minister, ensuring that they provide proper advice on how these tax, you remember the 2% importation tax that will go to health, will be used, will be invested in health, but also how they can work on reducing those inefficiency. So DRC is the first country out of 20. So those are concrete action. The CV of the expert have been sent to all the different ministers of health who are reviewing them. And once they agree, then they will be sent to those countries to start the support. I think that is very concrete. So, and how the IMST prioritize the response across different outbreaks. The IMST, it's serving the member states. So we have, like this morning, we have that meeting where we have the member state coming and highlighting the challenge that they are facing. They were talking about mpox, they were talking about cholera. So depending on the magnitude and the epidemiology, then we'll prioritize the type of response that we'll provide to the different countries. But also, if you recall, a few months ago, WHO called us, Africa CDC and other partners, to discuss about diphtheria, how this one can also be benefit from a coordinated way of responding. Last week, you heard about malaria with the initiative of Equatorial Guinea. So next week in Kinshasa, we will discuss together how we are going to have a new framework for the IMST, a framework that will include the preparedness and the response, and maybe also integrate other disease. It will be a discussion. Should we integrate diphtheria? Should we integrate malaria? Should we integrate any other? We will discuss and see, based on the capacity that we have, based on the different partner, what is the best way to support the member state. Over to you, Margaret.
Let's take the next two questions. Crossing over to the floor now, we have Melody from The Guardian UK. Melody, you have the floor.
Thank you so much. I appreciate you taking my question, and this was a great presentation. I did want to go back to the hepatitis B trial that I brought up a few weeks ago. The foreign minister of Guinea-Bissau said it's definitely off, but then last week, I think Dr. Kaseya said it's still being reviewed. I think with an Africa CDC team. What's the status of it right now? And the ability of the country to to review a trial like this.
Thank you, Melody. Let's take the next question before the response. We have Kumba from Gambia Daily. Kumba, you have the floor.
Thank you, Madam Margaret, for giving me the floor. My question is three questions, actually, if I'm given the time. The first one is about Gambia. Of recent, Gambia report diarrhea with blood on a weekly basis and indicated on the weekly dermatological bulletin of the Ministry of Health of the Gambia. An ongoing study, including Gambia, provided preliminary results showing that children 6 to 12 months are found to be the age cohort to be the most affected with Shigella, but no information on Shigella features in the bulletin. What is Africa CDC stand on this? The second question is about addressing the health sovereignty in Africa. And I would like to ask, how is Africa CDC strengthening Africa's capacity to detect, prevent, and respond to emerging infectious diseases while reducing dependency on external funding and foreign vaccine manufacturing? And the other question is, what strategy is Africa CDC implementing to addressing growing public health threats linked to climate change, such as increased outbreaks of vector-borne diseases and food insecurity across African regions? Thank you. Back to you, Margaret.
Thank you. Prof?
Okay, thank you so much. So I will let Dr. Mercy answer the question on the Shigella in Gambia, and also the one on the climate change and vector-borne disease. So thank you, Melody, for the question on hepatitis B trial. I think our DJ was quite clear on that the study was suspended, and then Africa CDC will see how to support. But I think we should really move to the comprehensive response support that we can bring to Gambia and other countries on the issue of hepatitis B. And Dr. Landry is connected. My say a word on what Africa CDC is planning to do as hepatitis B is concerned. So the question on the Africa health security, how we actually support country to detect, prevent, and looking at the reduction of funding. So the first thing is you've seen, we took the time to do a highlight on the laboratory presentation to see how Africa CDC and partners, WHO, as mentioned, were moving to support country to increase their laboratory capacity. As we do to speak now, I mentioned out of the 55 countries in the continent, we have 48 that have the capacity to do genome sequencing. You've also seen the improvement on during the mpox, how countries like Burundi was moving from 1 to 56 lab able to detect quickly mpox. You've seen also how we have that continental decentralization strategy to ensure that the different countries can decentralize with the support of our different partners. I think that's something critical. The other part is also on the side of strengthening the workforce. We have currently colleagues in Comoros, for example, who are supporting the strengthening of the EOCs, how the coordination of the response is happening. So those are some of the key things that are happening practically. And also we have the different FEMS, the training that we have within Africa CDC. So Dr. Landry, maybe first a word on the hepatitis B, then we'll go to Dr. Mercy on the Shigella and the climate change and vector-borne disease.
Yeah, thank you, Prof. Yap. Allow me to keep my camera off because of bandwidth issues here. I just want to add, I think you're right. We know the evidence. A single dose of hepatitis B vaccine administered within 24 hours of birth can prevent up to 95% of mother-to-child transmission, even in the absence of maternal antiretroviral therapy. You have the evidence. So universal birth dose implementation is a high priority for Africa CDC. But we know also that countries are facing challenges, and that the coverage of hepatitis B vaccination at birth, the birth dose is still very low on the continent. So for Africa CDC, it's a top priority to increase access to birth dose vaccination, and countries like Guinea-Bissau, as you rightly mentioned, prioritizing that strategy as part of the introduction of hepatitis B dose vaccination in 2027. Thank you.
Thank you, Dr. Landry. Dr. Mercy?
Thank you, Prof. Thank you, Prof. Starting with the Shigella situation in Gambia, it's really important for us to highlight that Shigella is not the only cause of bloody diarrhea. And so it might be very presumptive to say that it is the cause of the bloody diarrhea that has been reported. We received the reports to start with, but we can't for sure just assign Shigella as the causative pathogen without proper laboratory diagnostics. So we have other prevailing bacterial infections ongoing, like E. coli, salmonellosis, and others. So it's really something that we are following up on. And one of the key things that we're doing as an institution is ensuring that they have the right diagnostics to be able to conduct to perform laboratory testing for those populations. Regarding the climate change issue that was mentioned, it's also important that we are seeing, and we have also prioritized some of the ongoing diseases that, of course, are being driven by climate change. And like earlier mentioned in our previous briefing, we highlighted the rising prevalence of malaria, especially in highlands that were not reported before, like in Ethiopia, Kenya, Rwanda, and other countries. There's also growing expansion of Aedes mosquitoes, which of course are the vector causing or transmitting the parasite. We are also seeing growing flooding in, for instance, the southern region, where a number of cholera outbreaks are associated with climate change, as well as drought. But it's also important to highlight some of the interventions at Africa CDC that we're doing. And one of the key interventions around climate change is the launch of our climate change health strategy, which of course looks at different facets. And one of the key areas that we feel is important that we really emphasize and really advocate for partners to support in ensuring that this is being implemented is ensuring that we have climate resilient infrastructure. Because we see most of the infrastructure, the wash infrastructures that we have on the continent are quite vulnerable to the climate hazards and the climate change hazards. And so when we have flooding and so on, we have this infrastructure submerged, or we have contamination of water supplies, and which of course prone the communities to having some of these waterborne diseases. The second is also to use the climate data, which of course we've really not been quite robust on, to use the climate change, the climate data for early warning. And that way we are ahead of the curve. We are able to use it for preparedness. Those vulnerable communities were able to mount robust infrastructure for WASH, as well as ensure that they have vaccine supply, while ensuring we are able to catch up with some of the WASH infrastructures. So these are some of the things that we are doing, just to name a few, and we really endorse all our journalists. Maybe you can go through our climate change, our climate health strategy, which is, of course, it is on our website. Over. I can put it in the chat as well.
Okay, thank you, Mercy. And we are talking about meningitis in DRC. That is also one disease that is definitely affected by the climate change. And just to mention that in DRC, in response to that outbreak, they will use the MENATRAC vaccine that will also target the actual serotype WW that is currently the cause of the outbreaks. Over to you, Director.
Thank you. Let's take the next question. I'm crossing back to the floor. We have Rachel Abuja from the Nigerian News Agency. Rachel, you have the floor.
Good afternoon, everybody. Thank you very much, Madam Margaret. Prof, I would like to know, how will the African CDC ensure that the proposed digital health identity system protects citizens' data privacy, and let's say across different countries, because we all have our own. Nigeria is trying to push for this, and it's been taking time. because at the moment we don't have like a database that can let's say that can protect citizens to say, right? Because we still have like health emergency and people are being treated not knowing that they have low blood sugar or they have high, and you just find out that they treat them like at the end of the day, the doctors take the blames for any catastrophe that comes after that. So I would just like to know if you can expand further how this will benefit the continent and what good it will be. Let's not just copy, but let's copy rightly. Thank you and over.
Thank you. Let's cross back to the floor for the next one. We have Paul from the Lancet. Paul, you have the floor.
Yes, thank you very much for taking my question. I would like to ask a question on the HIV/AIDS response. We've seen a lot of growth, a lot of progress, a lot of acceleration in response, and but we've not heard much about how Africa CDC is involved. So I'd like to know the current involvement of the Africa CDC in the HIV response on the continent. We recently had several African countries rolling out lenacapavir, which is the newest tool for preventing HIV infection. So if there is an HIV experts on the call that can give me a much better perspective regarding Africa CDC's involvement and how lenacapavir rollout is happening, especially towards preventing HIV diseases on the continent. Thank you very much.
Thank you, Paul. Back to you, Prof.
Yes, thank you. So we have Dr. Landry, who is the director of the Center for the Primary Healthcare, which is leading the HIV. Will be happy to answer the question on that. So on the question of the privacy and how we support the member state, we do it at two levels. We start by the continental level. You remember I was talking about the Charting Africa Digital Public Health Future. And one of the 5 key points that we are highlighting is the building of the continental public health data center. And the aim of that is really to have that data hub that securely hosts and analyzes all the data across the member states. So we have that platform. This is very secure, where country will feel that the data will be safe. But then before reaching there, we have the support that we bring at the national level. And how does it work? You've seen the support that we've been bringing to the country in terms of EOCs, the strengthening of the EOC. So we have, as we do speak now, 29, which have completed the EOCs, if I'm not mistaken, and will continue to all the others. So on the side of the EOC, there is also the data center for that where country can maintain the intelligence. This is also something that the Africa CDC will support the country to improve a bit like what you can see currently in Rwanda or even in Ethiopia. So the idea is to scale that, and Africa CDC will be supporting. So for the question to Paul, I will turn to Dr. Landry on that. And for the first question, if Dr. Musoka see any need to complement, feel free.
Can I come in?
Yes, please.
Yeah, no, thank you so much, Paul. As you rightly said, HIV remains a major public health issue on the continent. It's not as spoken out about as Ebola or Marburg during our EOC meetings or during our press briefing, and I'm very happy that you brought it out here clearly. I think what is important to highlight here is that the continent remains highly affected in terms of the burden of the disease and as well as the burden of the infection. Close to 70% of new infection continue to be recorded on the continent compared to the rest of the world. And as you rightly said, we are going through an unprecedented era in the AIDS response with the findings or the positive findings of the LENA study. which led to the initiation by the Gilead company and partners like Global Fund and Clinton and Clinton AIDS Foundation to the major rollout of the lenacapavir as a new tool that can significantly reduce new infection among those who are at higher risk. And I think what is important to highlight is that lenacapavir is among the pre-exposure prophylaxis injectable. It's not the only one. Before that, we had cabotegravir, which was already utilized in some countries. But the main difference with lenacapavir is the flexibility and I would say the convenience for people using it, because it is given only in two injections per year. 6 months coverage is a significant change in the paradigm of HIV prevention, because not only stigma but also adherence has always been a challenge around HIV prevention. So for Africa CDC, in line with our Africa health security and sovereignty, HIV definitely, given the burden, given the impact, and also given the challenges that it brings to our population, is a priority not only in terms of access. So lenacapavir access is a priority for Africa CDC. Lenacapavir local manufacturing, and not only in the lenacapavir but all the HIV diagnostic and therapeutics are going to be already part of the priority for the Africa CDC platform for harmonized access to health, medicine, and therapeutics. I think what is critical here to also highlight is the role of the civil society, the role of partners, and more importantly, the role of our national governments, because the HIV response is going through a significant transition in terms of financing. Key institutions like Global Fund are playing a key role moving forward, but we need, in line with the health financing, as our head of state mentioned at the last EU summit, we need to increase systematically domestic financing. We need to bring in more innovative financing. We need to bring the blended financing to enable our member state and our private sector to take on the local production of commodities that will allow our continent to be more sovereign and more secure, and to tackle and significantly reduce the burden of diseases including HIV. Over. Thank you.
Over to you, Director.
Thank you very much, Dr. Landry. Let's take the next question. I have one here from Claire, is a journalist for Le Monde. The question is, Dr. Kaseya expressed last week his concern regarding the bilateral deals signed between African countries and the US. Could the sharing of health data with the US undermine the confidence of the public in their healthcare system? And how much of the America First strategy could affect the work of the Africa CDC? Back to you, Prof.
Yes, thank you, Margaret. I think that's a very good question from Claire, and an opportunity to re-emphasize the position of our DJ, who was highlighting that we have different categories of country. As we do speak now with the engagement with the US government, we have those like Zambia and Zimbabwe that have not signed the agreement with the US, and we have others like DRC who have signed. So the position of Africa CDC in support to the member state is to support both countries. So for the country who have signed like DRC is to support the implementation, and you remember highlighting that we'll have those finance experts that will be deployed, and we will be supporting the minister to have one plan and ensure that the funding that will come and support that specific plan for the country. Now, for those countries that have concern, the country, Zimbabwe and Zambia have some concern with the plan, is now to see how Africa CDC can support them to negotiate, to find out what are the critical challenges. Is it in the data, as you mentioned? Is it something else that need to be discussed? And then see how Africa CDC, because we have that position with our member state, but because also, as you remember, our Director General highlighting that we were the only organization that had that engagement initially with the US government at the highest level, which has kind of support and influence the American First strategy. So altogether, the message is quite clear. We are supporting our member state to implement for those who have signed and for those who have concern, to see how those concerns can be addressed. Thank you. Over to you, Director.
Thank you, Prof. We have one last question here from Ari Daniel. He's a science journalist based in Boston. Ari, you have the floor.
Hello, can you hear me?
Yes, we can hear you. Go ahead.
Okay, great. So I'm not sure who to direct this to, but my question is about the recent travel advisory around polio that the US CDC put out in reference to 32 countries. I'm wondering how the Africa CDC is thinking about this advisory. Why would it be issued now? How serious is it? And if the Africa CDC or any African countries are taking measures to halt the spread, or if you feel something else might be going on here. Thank you.
Back to you, Prof.
Yes, I will transfer it to Dr. Mercy, who is leading the surveillance for Africa CDC, which will be able to provide an answer.
Thank you so much, Prof. And thank you for that question. This is not the first time that the US government is putting up travel advisory to certain pathogens on the continent or certain outbreaks. And we know that for the most part of it, we have been reporting in Africa vaccine-derived polio outbreaks, but it's not new. It's not unusual. It's not wild polio. So this is something that even at Africa CDC, we have not activated because we feel this is not unusual. The numbers that are coming in are not unusual. So while there is that ability for every institution to set up their alert thresholds on the continent, what we do is that for the countries that have been reporting, we also support them to enhance their surveillance. For the most part of it, we are receiving a lot of alerts on acute flaccid paralysis, which of course is one of the syndromic mechanisms of detecting polio outbreaks. But again, we really don't want to overemphasize it, but this is not unusual on the continent. These are numbers that we have been seeing in the past years. And so we don't really see that there's a need for panic. I will end here. Over.
Yes, thank you, Dr. Mercy. And with that, we have come to the end of the briefing this week. I'll hand over the floor back to you, Prof, for your closing remarks.
Yes, thank you so much, Margaret. Thank you to all the journalists. I see a hand of Ari. Maybe we give the opportunity.
Ari, is that a new hand?
Yes. May I ask just one follow-up?
Yes.
I'm just wondering why they might be putting the advisory out now. What might be motivating that for such a broad range of countries on at least a couple of different continents? I understand this may be typical. These sorts of announcements have come before, but just wondering why now and what might be motivating this.
Okay. So thank you, Ari. I think you are giving me the opportunity to close our briefing. And you remember the vision of Africa CDC is Africa health, security, and sovereignty. So we are responsible to what is happening in the continent. So the question you are asking, we might not be the best position to answer. Definitely, the US government will be able to provide you the information why they are going to that. But in our side, Dr. Mercy has highlighted that at this point of time, it's not critical for us to have the same approach. But I really want to thank all the colleagues who have been joining, but the journalists, Yesterday, we were having some conversation with some consultants that are supporting us on thinking about the framework for the IMST, the JEEP, and all those partnerships. And one critical question that they ask is, how are we ensuring the accountability to our member state? And we believe that this conversation that we have every week is one of the most powerful opportunity for us to maintain that accountability, because through the question that you are asking, through the different follow-up, we have to be on top of it. We have to be transparent. And then we appreciate that after the briefing, quite a number of you will make some article, and we give back to your leaders and also to your community. So we really appreciate this effort that you've been doing for more than 15 months now. And then we look forward to see you next week at the same time. Thank you.